You ready?
I'm ready when you are.
Okay. All right. Let's go ahead and get going on started. Today, Dr. Grant is going to present a discussion on making business your business. Talking about how to transition and what you need to know when you're done as a resident. So Dr. Branch not only is our Mentees chief, but last night he was honored by the Arts chapter, the school chapter of the AOA, by being one of the residents named into, nominated and then accepted into Outstanding House.
Can y'all hear me okay in the back? Microphone's working? Okay, excellent. Thanks, Dr. Bocchini. So I came up with this topic, certainly during the last year. I've done my job search, I've signed a contract now, and when I started, I really kind of went in blind, which that's not good. So my goal today is to prepare you guys for what to look for and how to protect yourselves, thus the topic, making business your business. So disclosures, I don't have any disclosures or conflicts of interest. My only interest is making you guys safe in the next few years when you find your jobs. So objectives, so first off, I'm going to kind of prove that new physicians and those of us who are getting ready to find their jobs don't really have a great plan, and then I'm going to identify some ways for us to make better decisions, and then we're going to discuss the terminology that'll prepare you to make these informed business decisions. So I'm going to do a quick survey. So I guess we have some senior residents here. So show of hands of any of the senior residents who have started doing their job searches, or anybody that started doing their job searches. So Sarah, Amanda, Bo, you've got one lined up, I think. Ken has started. So did any of y'all have any formal training at all or anything at all before you started looking for your job, any contracts? Ever had any talks regarding this at all? No. Students and interns, have y'all ever had anything where you've talked about what it is to start looking for a job, where you should even begin? So I see like one head or two in the whole crowd that are nodding yes, and that's it. So clearly, as physicians, this is not something that we're prepared for or we're taught to be doctors. And I think that this is a great quote from Dr. Nate Gross, who is one of the co-founders of Doximity, which is a social networking site that's mostly for physicians. They do a lot of data compilation regarding average salaries across the country, with people reporting their contract salaries, and actually have an excellent map on their website that's interactive, and you can click through and look through all the different subspecialties and specialties and see what people in that part of the country are making. So he said they're residents going to look for jobs after residency, and they have no idea what they're doing. They weren't taught that kind of stuff in residency. They were taught how to be doctors and surgeons. And in the job search, they don't necessarily get screwed over, but they don't necessarily get what they deserve either. I think we all should get what we deserve, or as close to it as possible. So that's something that I found to be a profound statement. And a few other anecdotal things from some of our staff here. Dr. Bass often says in clinic, whenever we're discussing how to bill or how to take care of a particular patient, not sure how good you or I would look in orange. So just illustrating the point of being careful about what you're doing in your practice. And then Dr. Gill, of course, one of her favorite things to say is, do you want your family to be able to eat? So making sure that you're billing appropriately, billing a high enough or a low enough code. So things that are very important for us to learn about. So this is just it's a little bit of a dated graph, went back to 2005, but it just shows how physician debt and medical student debt is just going through the roof, basically. So point being that you're going to have, most of us, a lot of debt whenever you come out of residency, and you're going to need to figure out how you're going to pay that debt back. So first thing to do, where to start your job search. I think the first best question for you to ask yourself before you even bother talking to anybody is, what do you need and or want from your practice? This encompasses a lot of things. Finances, like I said, you're going to have a lot of debt. So how much income are you going to need to be able to survive, to do the things that you need to do, such as pay your bills, feed your family, and how much are you going to need to make to be able to do the things that you want to do? Definitely those two are different. So you need to consider that before you decide on your practice. The data for this is pretty easy to obtain through the internet. This group, the Medical Group Management Association, compiles tons of data regarding average salaries. I think their actual last group of papers that they put out or data that they put out was in 2013. So you can find the data out there. You can also use the other sites like Doximity, and there are plenty of resources that'll give you ways to find out how much people in your area are making and let you have a point of reference to go off of. The next thing, I think, practice setting. Really, what do you want to do? For me, I was interested in doing outpatient. I went into my first interview with one of the bigger groups in this area, and I had really no idea what I wanted to do, and they asked me, well, what kind of practice do you want to have? And I just basically stared at them with a blank face and said, I really haven't thought about that a whole lot, so I think that it's something, that I want you guys to realize you should think about, because there are a lot of different options. Inpatient only. Do you want to do inpatient where there's hospitalist groups and you're not working nights? There are ones where you're 7 on, 7 off, and you work weeks and nights. So there are tons of options. You need to consider what's best for your lifestyle before you commit to anything. Quality of life kind of goes along with the practice setting. So how much time do you want to spend at work? How much time do you need to be able to spend at home with your family? Obviously this changes after, once you have children, where are your loved ones, that sort of thing. So very important. And geography. Is geography important to you? It was for me. I knew I was staying in this area, so a little bit more limited number of people to talk to. If you're free in the wind, you can go anywhere, so it's a matter of considering these things before you really start looking around. So now you've kind of decided this is what I want to do. Where are you going to go from here? Who are you going to talk to? So some things that I have found on the internet that I wish that I would have known before. Offer sheets. So once you've decided what you want to do and you start reaching out to people, offer sheets are a quick, simple explanation of what a practice or a hospital is offering regarding, pretty much all the important points, but in a very concise manner that's not as in-depth as the contract, including negotiable and non-negotiable points that you're going to want to know about. Hits the high points, like I said, it's going to include salary, what your work expectations and hours will be, any incentives, if there's any night call, benefits, vacation, CME, holidays, all of these things. So we're going to talk more in depth about most of these as we go along. Next thing, dashboards. So if you're planning on going into a smaller practice or joining a group or a hospital, a dashboard is basically a quick business bill of health that you can ask for, and it's not an unreasonable thing to do. And if they refuse to give you one, they may not have it that day, but you can ask them to get it to you. But if they refuse to give you one, then it should be a relative red flag for you wondering how the financial status of that business is. So what it does is it provides examples of that job's financial health from a number of different things, and this is just a limited sample of what it can actually include. But payer mix comparisons, what I mean by that is how many Medicare versus Medicaid versus privately insured patients are you seeing? Are the senior physicians in the practice the only ones seeing the privately insured patients, and they're shoveling all the Medicare, Medicaid, and uninsured people to the new physician in the practice? So important to consider. Next is RVUs, which I'm going to talk more about that, so don't worry about the terminology too much just yet. But volumes and comparisons, basically how much money are the physicians making, how many patients are they able to see, and how much are they generating from that. Impact of time off on revenue and RVUs. So if you're not there for a day, what's going to happen to your practice? What's going to happen to your income? Very important. New patient visits and consultations for the current month and even the year to date. So how well is your practice thriving? Are you getting lots of outside referrals from other physicians or new people wanting to come? Or are you not getting new patient visits at that clinic? So a quick way to assess, is this practice growing? Do they actually have the need for me as a physician here, or are they just using me to take care of some of the less well-funded patients so that they can fund somebody's retirement as an older physician decides to go out of the practice? And then, like, it's similar mold there, next new patient appointment. So how far out are you booked in that clinic? So it just tells you a quick reference for how busy that clinic is, how many patients are coming there. So easy things that you can ask them to provide you with, that you can look and say, okay, this practice really could use me, as opposed to they just want me here to help them with something that is more of a problem. So I thought this was kind of an interesting point that I actually got from Dr. Bass' background check. They're going to background check you, so you should background check them in turn. Easy to do, really, and not inappropriate at all, even though you may feel that it is. You can ask to speak with hospital administrators, referring physicians to that clinic, medical directors, any of the staff that are available at that clinic. If they say no, again, red flag, because they should want you to know what's going on in that practice so that you're aware of how everything works, how happy the people are working at that clinic, and how happy other providers in the area are with sending their patients to that clinic. That's how you're going to get your money, bringing patients into the clinic. So you want to know these things. Also, quick and easy things to do. There are plenty of physician rating sites on the internet. You can Google them. You can look people up in a matter of minutes. So quick ways to do these background checks, and it's something that'll give you, again, a good idea of how that practice is doing in general. So now that we've kind of had a brief way that you can look at the practice that you've decided on, things get a little bit more technical, and this is certainly a wall of words, and then we're going to break it down and go through most of these piece by piece. Obviously, it's much larger than what I can talk about in an hour, so we're going to talk about all of these different things, at least briefly, so that you have some idea of what to look for when you go into your job search. So how do you protect yourself, and what do you look for in your contracts? So this is a quick national salaries average that I pulled off of the internet. Doesn't include signing bonus, relocation incentives, and loan forgiveness, and a number of other things like that. So it's extremely variable. The Southeast in general has higher average salaries for all primary care physicians pretty much across the board as compared to the North, the West Coast, the East Coast. It's supply and demand, so you're going to get paid a bit more if you're in the Southeast. So work status, that's kind of the first thing, is who are you going to work for? Are you going to be an independent contractor who is brought in to do a specific job? Are you going to work for a hospital or a group as an employee? Or are you going to be a partner or a shareholder in that group? Or there are kind of new things coming up that are accountable care groups that I'll talk about at the very end. So productivity, this is a big one. So most contracts have either a base salary or an income guarantee, which I'll talk about both of those, and then an amount to be paid as a bonus based upon how much work you're doing or how much money you're generating in that clinic or in that practice setting, inpatient or outpatient. There are a lot of models for this. They're fairly complicated. I'm going to try to break it down for you as simply as I can so that you understand what to look for. So billings versus collection pay. So just for reference, we're going to give you that base salary of $160,000 that was on the slide a few back. So if you have productivity based upon your billing, after you bill $160,000 and cover any overhead costs that you may be having, you're going to typically get a set percentage back. The standard is usually around 50% of anything you bill paid back to you as a bonus. The bonuses can be paid back quarterly, annually, however you kind of agree with the practice that you're joining to do it. So the next thing is productivity based upon your collections. So this is anything you bill for that actually gets paid back to the clinic. So if you collect $160,000 from billing and cover your costs, then you get paid approximately that same 50% of what you're collecting back. So it can be tricky. Things to look for: if you're seeing a larger portion of uninsured or Medicare, Medicaid insured, then your billing may be more limited because you're not able to charge for as many things. They're not going to pay for as many things often. So you have to be careful because often practices will give new physicians a larger share of these patients than the more established physicians. So you got to be careful because that's going to limit what you're able to generate. No matter how hard you're working, if you're in there killing yourself every day, working as hard as you can trying to get new patients in, you still may not be able to generate as much money because of the fact that you're not able to bill and collect as much. So busier, but not able to make as much money as the senior people in the practice. So a place where definitely we as new physicians cannot get what we deserve. So RVUs, this is one of the other major billing models that you're going to come across. Whenever I started talking contracts with people, it was in at least 2 of the 3 different people that I talked to. I had no idea what it meant. I had to Google RVUs and look and see what the definition was. I had no idea. So quickly and simply, it's a measuring tool that determines how much you have done as far as your work. So a higher acuity patient is going to generate more RVUs, so you're going to get paid more productivity based off of that. So quick and easy, it's not quite this simple, but if you bill, say, a 99213, you may be reimbursed or given 0.8 RVU or relative value units for that visit. If you bill a 99214, it might be a 1.2. So as you can see, higher acuity, you get a little bit more value for your time. So most of the contracts will set an RVU goal per year. Then you're paid a set rate per RVU after you have billed above usually your base salary. So once you bill more RVUs, for instance, if you're getting around this $38, which is kind of the average RVU compensation for pediatricians, if you bill above your $160,000 base salary that we set, then once your RVU amount times that $38 equals 168, you're going to get $38 for every RVU above that, basically. Makes sense? Clear as mud, hopefully. And then there are often other things that are tiered RVU pay plans. So if you come out in your first year, mine in particular, like my first year, I'm required to get a lot less RVUs to meet productivity. So you can watch out for those sorts of things. I think I have to get around like 4,500 in my first year. Then the next year it goes up to like 6,500 that I'm expected to generate as the practice grows and matures. You're seeing more people. I think that's sort of a standard, way that things are handled. So other things that are important to know that I didn't put on here, over the long term, if you end up working with physician's assistants or nurse practitioners, then often physicians will get a percentage of their RVUs back as compensation for being the supervising physician in the practice. So if they're billing, you may get 0.4 of an RVU for a patient visit that they've seen. So you're going to get some compensation for being the overseeing physician for that as well. So other things to be aware of, pay based on patient satisfaction is becoming a bigger and bigger thing, and I'll talk a bit more about that as we go along later. Profit sharing across groups and partnerships. I'm not going to get into a whole lot of these. Resource utilization incentives, and that basically means if you do more of this procedure or use more of this or less of this procedure, we're going to pay you more or less money depending on how your practice is running. And then actually ran into this in one of the contracts that I looked at when I was doing my job search, is limits on your productivity pay. One of the contracts that I looked at basically had a cap on, if you see X number of patients per day, then we'll pay you this number of dollars per quarter, which leaves you with very little incentive to work harder because they're not willing to compensate you anything more for any extra work that you do. So to me, that was very unappealing, not very entrepreneurial, so to speak, in terms of, being encouraging of you to try to do more, see more patients, make your practice grow. So I know this is all tedious, so I wanted y'all to have something to keep you awake for a second and to give me a chance to sip a little bit of coffee. So this is unfortunately how we often feel throughout residency. So back to it, income guarantees. So I'm going to get into your salary and your income guarantees. Income guarantees and base salary are a bit different. I'm going to talk about it. So an income guarantee is the amount that you make, but it is different from a base salary. This is where an employer guarantees that you're going to make X amount of dollars per year. But if you don't generate that amount of money, they'll pay you the difference back. So if you made $150,000 into your practice off of that $160,000 salary, they'll give you the other $10,000 to make up the difference. But you owe the amount of money back to them at the end of a predefined period unless they give you a forgiveness of guarantee, which I will talk about. So base salaries, this is a set minimum amount of money that you're going to get paid for either the year or the duration of your contract. So the difference is that you don't owe the money back if you don't make up to that on your base salary, if you're not generating that amount from your clinic. But be aware, some base salaries may decline each year as your productivity pay goes up. So you need to be careful. They can also write that it's okay for them to adjust your salary after an annual review. So you need to be asking, whatever group you're going to work for, how many times have you done this to other physicians? If you have them set at a base salary and it's okay for you to adjust their base salary at the end of a year, how many times have you actually done that to people? What was the justification for it? Were they happy about it? Was it because you were upping their productivity pay? So just something to look out for. Came across that in a contract as well. So forgiveness of guarantees. This is basically where your employer agrees to forgive that amount of money that you owe for the income guarantee at the end of that guarantee period. In exchange, often the physician just says, okay, I'm going to keep working here. We'll keep trying to grow the practice and see if we can make it to where I'm billing more than that, and then you don't owe the hospital. The terms are usually 1 to 3 years, which what that means is at the end of your initial contract, you would owe them that additional 1 to 3 years to compensate for that money that you owe back to them. So it assures the hospital of continuing services so that they don't lose a doctor, and the physician continues to get paid, of course. But you kind of need to beware again, if you want to leave while you're in that guarantee period for 1 to 3 years, you're still going to have to pay that money back to be released from that contract. So basically the simple of it is the hospital is getting either repaid with your time or your money, one way or the other. Also, it's a little bit of you as far as, the faith that you're going to be able to grow the practice. If you're right there, it's the end of your initial contract, but things are going well, starting to pick up, you may be more willing to say, okay, let's stick this out, make it work. We're going to be growing by the time the next contract comes up, and then we can renegotiate so we know we're growing. So next topic is non-compete clauses or restrictive covenants. This was a really big one in particular to me, and I think it should be to most people depending on where you're going to practice. What this is it's a clause that's designed to prevent a physician from leaving a practice to the detriment of the employer, essentially. Oftentimes they'll have a distance associated with them, as far as if you have a practice here, you may not be able to practice within a radius of 10 to 20 miles from that practice site. It can also include any practices outside of your contract. So they may say you can't do anything outside of working for us, moonlighting, so you need to kind of make them be specific about it. My contract initially had one in. I'm moving to Monroe, which is where my family is at, and I told them, I'm moving home. I'm not going to sign anything that has a no-compete clause in it because I'm not planning on moving again, and if things don't work out, I'm not going to uproot my entire family to go find another job in another city. So it is actually important. It doesn't seem necessarily like a big thing. Sarah? Yeah.
Does it have to do with once your contract is over, or if you break your contract, or both?
Yeah, it can be both. Both. Yeah. It can be for the duration of the contract. It all depends on how they put the legal wording in your contract. This is illegal in some states, entirely illegal, can't be done. So depending on where you want to practice, you need to look out for it. I will say that from what I have gathered from speaking to a lot of outside physicians that are in primary care, it's fairly hard for them to get these to stand up if they really want to, get to a legal battle over it. They actually have a hard time getting them to stick. You're better off just beating that up front so that you don't have to get into that. Another thing is the more specialized of the practice you're going into, the bigger of the restriction area you're usually going to have versus primary care. For instance, for infectious disease, we cover a very, very large portion of the state because we're the only people who have peds infectious disease here. So if somebody was to have a non-compete It would have to cover a very large area if you can't go set up another practice in Monroe or Alexandria or these things, so that your patient pool for that practice stays the same. Whereas for primary care, 10 to 20 miles is kind of what you see in most of the contracts, because you can pull that many patients to your clinic and still be able to run a clinic effectively. Hours and call, most importantly, needs to be clearly defined within the contract. So any terms such as appropriate or fair or accepted within the medical community at this time are unacceptable, because that leaves everything open to interpretation of the contract writer. No good. That will back you into a very bad corner that you don't want to be in. So hours, the max number of hours needs to be defined. The expected work hours should be defined. My initial contract had a requirement in it that said I had to be in my clinic for a minimum of 50 hours a week. For me, that was sort of unacceptable, because I'm doing clinic only, so if I'm done with my billing, my papers, documentation at the end of the day, I didn't want to be stuck spending another 2 hours just sitting in the clinic waiting around, because at the end of the year I didn't want them to be able to say, well, you didn't spend 50 hours in the clinic this 1 week, Dr. Branch, we're not going to pay you your bonus this year. So something to be aware of and look out for again. Call, so we all know what call is, so you just have to be specific about it. Like I mentioned, if you're joining a group, the call plan should be divided equally amongst everybody. You really shouldn't settle for much less than that. Just because you're the new physician doesn't mean you should have to work all of the hours. Duties and vacation, what are you expected to do? Where are you expected to do it? When should it be done by? So, am I expected to have all of my notes done by the end of the day? My billing done by the end of the day? Obviously, most of the times, yes, that is the case. But are there any extra responsibilities? Several of the contracts I looked at had extra kind of built-in things, such as you could be subject to ER call at any point in time that we feel like it, if we decide that we need to call you and tell you, hey, you need to come work the ER here. If you don't want to do that, tell them I'm not doing that. Negotiate it. I said, I'm not working in your ER, that's not what I'm trained to do. However, you have to take this out of the contract or exclude me from it, make it happen, and then we'll talk again. If it's not negotiable, then it's not negotiable. So fortunately for me, they were happy to do that. But you need to be sure that the responsibilities that you're expected to do are explicitly defined in your job description. Vacation, the amount really depends on what you decide to go into as far as your specialty and your type of practice. Most primary care is typically 3 or 4 weeks per year, especially like for clinic work. They gave me 4 weeks off a year. Probably I'm not going to take that during the first few years, because I want to be as available to my patients as I possibly can. That's how you're going to grow your practice, is letting people come through the doors and come to see you. So you just want to make sure that they have it defined for you. Like I said, very variable amongst specialties. Radiologists, the new, acceptable norms for them is more like 8 to 10 weeks of vacation per year now. So you need to know what you're getting into. And then, of course, what days are paid holidays? Are you going to be expected to work every Christmas, New Year's, Thanksgiving, and all of these things? So find out what the paid holidays are, or how the call rotation will work for those holidays. I thought this one was pretty funny, and hopefully you don't get stuck in this situation after you get out of residency. Exactly. So partnerships. Very important. Lots of people end up in this after they get out of residency. So if you're joining a group or partnership, the pathway to partnership needs to be very clear. So this needs to tell you if there are any requirements, whether that's a length of time or a buy-in, or that are present to get to be a partner in that group. It needs to be in the contract, and it needs to be clear. Avoid ambiguity at all costs. You don't want things like, we'll make you a partner when your practice is mature, or when our expectations are met. Those aren't acceptable, because they mean anything that the person who is the employer want them to be, basically. So they could delay you from being a partner as long as they wanted to, because who knows what that means. So benefits, I'm really only going to go into the malpractice insurance out of these, but the others are pretty standard. Health insurance, malpractice insurance, disability, and retirement, of course. So malpractice insurance, didn't really know anything about it before I started doing this. So two real primary types, claims made and occurrence made. Claims made only protects you if the company that's insuring you at the time of the occurrence or the claim happens is filed at the same time of like when the file is in court. So it's a little bit tricky, and I'm going to talk about why. And then the occurrence made is a seamless coverage for you as far as your malpractice, regardless of where your job or location is at, as long as the coverage is in place at the time of the alleged incident. So tail coverage, this is important because it covers you with claims made type malpractice insurance. If you change jobs, insurance companies, or practices outside of those what are already covered, this covers that gap that's left if you happen to change jobs with the claims made type. It is expensive. It's usually 1 to 2 times the typical annual malpractice premium, but you pay that once and you're covered in most cases. So important to know who's going to pay or provide for your malpractice insurance. Is it the group that you're working for, or are you expected to pay for it every year? The rates are variable based on geographic location, national and local scale. So most of the time, from what I could find, it's hard to find these actual rates online. But it looks like for most primary care physicians, you're probably going to be expecting to pay $5,000 or less per year as far as your malpractice. You may not have to pay that. Whoever your employer is may pay it. My employer is going to pay for my general malpractice, and then I have to provide tail coverage of my own for any practice that I may do outside of my clinic that I'm going to be in. So that way they don't feel like they're going to be liable if I decide to treat somebody outside of the practice of my clinic and that person decides that there's a problem and wants to come after me. I have other coverage that is in place already. So the costs and the actual rate of claims for malpractice have been dropping for over a decade now. In 2003, there were about 17,000 paid claims, nearly $4 billion. By 2011, it was less than 10,000 paid claims and less than $3 billion paid out. So it is getting less. Tort reform, obviously, everybody has heard lots and lots about that. Louisiana actually has a cap on the total amount paid out, the actual complete total for any malpractice at $500,000.
That includes judgments made and settlements?
Yes,
yeah.
It's like the total for everything can't exceed that for a malpractice claim, as far as what I read. Okay. Next, termination clauses. There are with cause and without cause termination clauses that you need to be aware of. So they're actually very common in your medical contracts. So termination clauses with cause, of course, they're going to have objective things that if you do this, you can get fired. So they can include loss of hospital or prescribing privileges, inappropriate conduct in your practice, any number of things. But it's something that's set. If you do this, you can or will be fired. Without cause termination clauses, they allow the employer or the employee typically to terminate a contract with 30 or 60 or 180 days notice. It just kind of depends on the contract. Basically, it's sort of a protection for you as well. I actually have one of these in my contract. It made me very nervous at first because I felt like it was a lack of faith from the people that I was signing with, so I started calling people, and everybody seemed to think this is fairly standard. They're not going to just terminate you, because if they do, whatever group you're with, it's going to ruin their reputation. Nobody's going to want to work for them. So you do need to you can ask questions like, well, when was the last time that you used this? If it's been used frequently, red flag. You can ask to talk to the last person that was terminated like this. If they say no, red flag. So you need to be aware of the reasons why this would have been done and how often it would have been done as well. Basically just not something that I think that most practices really do that often, but it protects them and you from bad situations. So marketing is a big deal. You're getting ready to go into new practice. How are you gonna sell yourself? So ask your employer, how are they gonna sell you to the patients? How are they gonna put people through the doors? Are they gonna put you on billboards, social media, TV, newspaper, ads, radio spots? Whatever they're gonna do, they should be able to explain to you a plan. And this should all be in place and planned out before you actually start your practice. Continuing education is kind of straightforward. How much are they going to pay for a year? What kind of things are they willing to pay for, and how much can be spent on things like in-office resources, whether that's like UpToDate, Medscape, any of your online resources. What are they willing to pay for to help you have these things? So in summary, review the contract closely, then review it again, and have an attorney that's experienced at looking at these things to review it for you prior to signing is something that I would very highly advise. Always read the small print. The contracts are very long typically. It's very tiresome and difficult to muddle through, but it is very, very important that you go through each and every point. That way you don't miss anything that paints you into a corner that you can't get out of. So next, this actually was one of the things that I got from one of our former residents when I asked him what was the most important thing he felt like whenever he came out of residency to private practice. Who will you work with? What he told me was, I thought that I was going to be the limiting factor whenever I came out of residency in terms of how many people we could see in a day, but that really wasn't the case. The staff around you kind of makes or breaks you, which I was surprised by as well. So important then to know, are you going to be allowed to help with the interviewing process for the people that you're going to work for? So the group, or the hospital I'm going to work for has already told me, we want you to come in whenever we're doing your hiring interview with us. That way you have a feel for the staff that you're going to have in your clinic, if you can work together, if everybody's going to be happy together. So is the hospital going to provide the staffing, or the group going to provide staffing, or are you expected to do that is another important point. What ancillary services are you going to have available? Will you have nutritionists, caseworkers, social workers, all of these different things? Are they going to be at your disposal? Will they be in your practice, or will they be at another site? Just things that you should look out for so that you know what services you'll have the capabilities of getting. It's simple for us here, because we've always had everybody that we can pick up and call that are in-house for the most part. When you go out in the real world, they may not be next door or down the hallway to where you can go grab the pediatric cardiologist or infectious disease doctor. So you need to know who's around, who can I call, who can I talk to, what kind of help can I get. Other things, how many nurses, PAs, nurse practitioners, all of these things are you going to have in the clinic to help you with? How are you going to generate those patient visits? How are you going to get people in and out, and how many staff are you going to have to help you do that? So go team go. The reason I put this is because I think that team morale is probably one of the single most important things as far as your practice outside of this and in residency, honestly. So three quick strategies to retain quality employees. Staff engagement, so let your employees come to you or whoever is running your group and talk to you about things that can be improved to make the whole process go more smoothly. Lets them feel involved, helps you out on the back end because there are often things that you're not involved in that you're not seeing that are going on. Care teams, so this is kind of where everybody has their role. You set up people to overlook various parts of how a practice is running. That way they can bring up any issues, have a whole team of people that are delegated to find out how to deal with that problem. And getting paid for the work. Recognition, it's not always just the money, which clearly says maybe extend beyond the wages, whether that's flexible hours, rewards of whatever kind, employees of the month, you as the physician bringing lunch one time a month. Anything small, it doesn't have to be a big deal, but anything that you can do to keep the morale happy at your practice is going to make things run better. Your patients will pick up on this, and they're going to say, okay, everybody's happy here. This is where I enjoy to come to as well, and that's going to be good for you in the long term. So kind of brought this up a little bit already. How am I going to get patients? Obviously, that's what we're in the business for, is getting patients. It's what we enjoy. So our marketing I already talked about. Are you going to join an established practice that already has a huge reputation where everybody's coming to that clinic anyways? Referrals, or people being referred to that clinic, goes back to the things I talked about earlier of asking to see how many patients are referred into that clinic from outside practices. Or the rotational placement of patients, and if you're in a group, do they give you every third new patient that comes in? So simple things that can tell you how are people going to get through your clinic doors. Do you have to go to the ER to do ER admissions? Do you have to do nursery call to get new babies into your clinic? Billing and coding, the topic is enormous, so I didn't really go into this much. I think if anything, we probably learn a little bit more about this than we do any of the rest of it in residency. So some things to ask about are, though, is your billing going to be handled internally or externally, and who's going to do that? A red flag for you as a new physician if you're going to a practice should be if you go to a practice and the person who's the head of the group's family member is doing all of the billing. That should be sort of worrisome for you. So just something to look out for. It does happen. Are they going to employ a billing professional? Who are you going to be able to ask about your billing and coding questions if not? It's how you're going to get paid. And I know I'm making this sound all about, am I going to get paid? Am I getting paid? And we're not entirely only in that for this, but you are in it for this. You have to survive. ICD-10 is coming like a freight train. Complete transition occurring October of this year. So it's going to be a big deal. It's going to require time for training, whether that's for you, whether it's for your clinic staff, your billing staff, whoever's going to handle these things for you. It's going to make you have to document more, so it's going to eat up more of your time. The AMA estimates that for established clinics, depending on their size, it can cost as much as $56,000 to $200,000+ for a total implementation of ICD-10. So it's going to be a big deal. Integrated into a lot of the EHR systems, and that seems good, but the question is that really true? Talking to Dr. Bienvenu in clinic the other day, some of the things that we're going to run into is it's making you be more specific with your billing, but often that's turning codes that were previously billable into V codes, so you're not going to get paid for those things. So you have to be aware of what these billing changes are going to mean for you. Look through the practice's most commonly billed codes. That'll tell you how are we going to compensate for this? What do we need to be coding? And to ask those questions so that you ensure that you're getting paid for your services. It's also probably going to slow the return of payment from insurers because they're going to have to figure out what they're paying for now as well. So it's going to present some upfront difficulties whenever the full implementation occurs. That's going to be particularly difficult for smaller practices that may not have as much income that are flowing through the clinic. Other bigger groups are going to be able to absorb and eat those costs for a little while. So still important to know about. HIPAA, I think that sometimes this is how we feel about HIPAA, but it doesn't seem as serious, but there really are a lot of fines that you can get burned on. $100 up to $50,000 with a max cap of $1.5 million. So it's really actually a big deal. Breaks in your physician-patient confidentiality, can break your practice down. People don't want their business out on the streets. It's becoming more and more difficult to control with the electronic age. All it takes is somebody taking a picture of a hand with a chart that's in the background with somebody's name on it. It's just something that's very difficult to control now. So social media just needs to be out of the clinic pretty much entirely. There are also some things that I didn't know about. So really for HIPAA and your meaningful use milestones, which are big ties into Medicare and Medicaid, you're supposed to be performing security risk analyses, meaning how are we protecting all of our patient information that's protected. So they want to be able to see those things, and they can come in and audit you at any point in time. If you fail them, you can get reimbursed less money based off of your billing. Affordable Care Act, I didn't go into this a lot, and again, just a huge topic, but there are potential for increased claims denials based upon very minute details. As I mentioned, even so far as misspelling the name in the chart. they can say, oh, this isn't the right person, we're not paying you for that. Some coverages require care in the physician quality reporting system, otherwise you can be penalized, and this is actually forcing some providers to abandon accepting insurances, especially Medicare and Medicaid altogether. So another potential issue is that there are changes in the health plan coverages patients don't know about. They may lose their insurance, lose their coverage entirely. It's going to make your life more difficult, more time documenting, reviewing your charts, thereby eating up your patient care hours. So it's going to increase your time and your staff's time spent battling to get it reimbursed. One of the other tricky things, patients can have a 90-day window to pay their premium in the Affordable Care Act. If they come to you in that 90 days and then they never pay their premium, they are not insured. Therefore, you will not be getting paid for it. So you need to discuss up front or have a plan up front with your patients of how are you going to pay for this visit. It's better if you're just straightforward with the patients. Don't leave them with this area where they can get burned that you know about. You know, most people are embarrassed to not be able to pay, so it's better if you just ask up front when they come in, how are you going to pay for this? The plans also often have very high copays that you may not expect, so it may not be really affordable for your patients. Burnout, I know that Dr. Broussard and Dr. Rice talked about burnout earlier in their grand rounds this year, so it's something to be aware of. With the increased demands that are going to be put on physicians, there's less time for patient care and teaching, which is what we do. That's what we love. That's what makes us go to work in the morning. So a couple of decent things here. I thought a recent survey from the Physicians Foundation showed that 81% of physicians that reported felt either overextended or at full capacity already. We all know that the baby boomer generation is getting ready to get older. There's going to be, for pediatricians, obviously not as big a deal, but for the med-peds people in particular, going to be a lot more people to be seen, and who's going to see them? We have a shortage of doctors nationwide. Other thing is prior authorizations are a huge time burden. Dr. McGuire, if she was here, spent quite a bit of time fighting this in clinic yesterday, I saw. So the Kaiser Family Foundation is a study group that showed that about 868 million physician hours were spent yearly on prior authorization activities. It's an amazing amount. Practice costs are going up more and more, so more technology, malpractice insurances, health insurances for your staffing, all of these things are going up. Who's going to handle it? I put down there at the bottom. So who's going to absorb all that cost? So the MGMA reported a median cost of business operations staff of $52,000 per full-time equivalent physician. So for one physician, the median cost of the staff, at least $52,000 at minimum. And then, of course, the ICD-10 costs I already talked about. Value-based payment, getting back to this, it rewards quality of care and outcomes, not your fee for services. So the more you see doesn't mean the more you make. You can get financial penalties, like I mentioned, for not being involved with the physician quality care reporting system for Medicare and Medicaid. Docking 1% per year, that's actually happening actively anyways, and in 2017, everybody is going to get docked, like it's going to take another % of reimbursement off. So insurers getting more power over how you practice, it's going to erode physician satisfaction because ultimately limiting our control on what we can prescribe and what we can do for our patients. They can cut you from the networks at any point in time, basically. So then you have to fight, how do I get back into the network to get paid by this insurance? It's unfortunately really going to move care away from being patient-centered. It's going to be dictated, a lot of it, by what you're going to be paid based off of these quality outcomes and value-based payment. So this is a chart that demonstrates some Medicare incentives and how the payments are going down. So more Medicare penalties, you're getting paid less. It's actively happening. Accountable care organizations, I said I would come back to. It's only brief. These are basically big provider groups that will care for a specific group for a specific amount of time. requires a lot of money to run these practices, and a lot of times they're poor business models because of that upfront cost. The payment that you're going to get that one time may not be enough to continue funding a full group of physician salaries, so you need to be aware if you're joining one of these practices that it may not be the ideal thing. You may need alternative sources of income as well in case it folds up later on due to the inability to fund everybody there. So in summary, you need to know what you want and you need from your practice. Do your homework before accepting a position. Take your contract, review it thoroughly more than once. Take it to an attorney who is experienced dealing with these things. Look out for these potential pitfalls that I talked about. They're out there. You just need to be careful. And like I said, I think one of the biggest things to help protect yourself is get professional care or professional help reviewing those contracts. And those are my resources. Hopefully you guys are a little more confident and will know what to look for now.
Along your job search, did you encounter any offers that gave incentives as far as loan repayment or as far as
that is out there, certainly. I don't have any loans, fortunately, so
well, you suck. You can't.
yes. I know. I hate to admit that in front of this crowd, but it's true. So I didn't have to deal with that too much, but there are definitely loan repayment incentives.
Yeah, there's federal government repayment if you work in like underserved areas. Like some that'll pay like $25,000 for 2 years that you work with underserved population.
Right, and there's actually scholarships, especially in Louisiana, that will do the same things. If you go into underserved areas, which underserved areas sounds bad, but Monroe qualifies as an underserved area. Cities, these places are all underserved areas because it's based off of physicians per capita, pretty much. So those are definitely available. Even in places that aren't, a lot of times the groups or hospitals are willing to help with the loan repayment as part of your contract, though. It's not uncommon at all.
So there is another, which I think is really important for medical students and residents to know about. There's something called the Public Service Loan Forgiveness Program. If you guys have never heard about it, you should Google it. There's a lot of information about it, and actually while you're in residency, a lot of people end up deferring their loans, but that may not be the best thing for you. Of course, it kind of ties into what Billy's talking about because you really need to know, and it's hard when you're a medical student and when you're in your first year, but it does matter what kind of field you want to go into. So for example, if you're planning on either doing primary care where you're working at a private outpatient office, that makes a difference as opposed to working at a hospital that's a not-for-profit or doing your fellowship, because the Public Service Loan Forgiveness Program, you don't have to be in an underserved area, but you can get your loans forgiven if you're working for a not-for-profit institution. And so it really is something that everyone should look into because, for example, I went to a Caribbean medical school, and so I've got a lot of debt. Unlike Billy, I do have a lot of debt, and so it was something that was weighing on my mind because when you're looking for a job, which I'm doing right now, you really, even though it's not all about pay, it is about your patients and being that physician, but you need to think about your own financial situations as well because it does play into when you're looking for a job and what you're planning on doing because, I mean, you have to think, that's the reality of the situation, you have to think about it.
Exactly.
And so for me, doing the Public Service Loan Forgiveness Program was an amazing thing because I was paying back my loans during residency, and like my first year of residency, I paid $0, and that counts. I paid $0 a month, and that counted towards my repayment. And after you do 10 years of this working in a not-for-profit institution, which residency counts for that, fellowship counts for that, and most hospitals, if you're working in a hospital, will be a not-for-profit institution.
Willis Knighton is a not-for-profit. not-for-profit
Huh?
system. Willis Knighton is a not-for-profit system.
Most of them are.
Like,
I mean, there's a
big-
lot of them.
Yeah.
You would be surprised how many hospitals, even private hospitals, are not-for-profit institutions. And all of that counts, and you pay much smaller, and after 10 years of payments, you get your loans forgiven, which is an amazing thing, depending on the amount of loans you have and things like that. So if you've not ever looked into it, you need to look into it, but you also need to take into account what you're planning on doing after residency, because it matters.
Any other questions? So Billy, did you engage a lawyer at the time you received the contract, or did you? have
Whenever
the
I
lawyer
had
help
the
you?
contract, I got somebody to look at it. Yes, sir. Whenever, so I went and talked to them. I guess about 3 weeks later, they got me the the first draft of the contract, and I took it and had somebody look at it.
All right, well, thank you. This was a very nice presentation, and